Endometriosis is a condition where you have the lining of the uterus, endometrium, present outside the uterus. And the tissue behaves in a similar way to the endometrium. So it responds to hormonal changes within the menstrual cycle. And after withdrawal of the hormones with bleeding, it does that in a similar way. And given the location of the tissue being outside the uterus, that blood, if it's, let's say, inside the abdomen, can cause inflammation and irritation. And that process of inflammation and scarring results in the manifestations that you could see with endometriosis. So endometriosis is a common condition. It's estimated to affect more than 1.5 million women in the UK. It's a disease largely of the reproductive age group, so it commonly affects women between the age of 25 to 45. That's a common age of presentation. And the disease itself, the endometriosis tissue can be, or the lesions, can be present in different parts of the body. The common site for endometriosis lesions is in the pelvis, in the lower part of the abdomen. So the area behind the uterus, the area in front of the uterus, the area around the ovaries, around the fallopian tubes, or behind that area. And the lesions, of course, can also be in distant parts from the pelvis. So you could find lesions on the peritoneum lining the abdomen further up. You could find them on the diaphragm under the liver, and you could also sometimes, on rare occasions, find them lesions in the lungs. So it can have different manifestations. And the lesions can be either superficial or they can be deep. So the level of how they affect the tissues and the clinical picture they present can vary depending on where they are and how much scarring and inflammation they cause. Endometriosis is treated depending on what problems it's causing. So you could look at it and say, women may present with pain, which is a common presentation. So pain could be present as pain before the menstrual period, with the menstrual period, or pain during sexual intercourse. But also sometimes this inflammation and scarring can affect the chances of achieving a pregnancy. So many patients may present with fertility, and many present with both pain and infertility. So treatment will depend on what the problem endometriosis is causing. So if we look at it from a pain perspective, the treatment could be either medical or surgical. And medical treatment largely relies on suppressing ovulation to stop the hormonal stimulation to this tissue. So hormonal treatment in the form of progestogens or the combined oral contraceptive pill, or surgery where the lesions are either excised or removed to help control the symptoms. So endometriosis generally regresses after the menopause because the hormone levels drop, and as a result, the tissue doesn't get the hormonal stimulation that keeps the tissue active. However, it is important to keep in mind that in a small proportion of women, endometriosis lesions can continue to cause symptoms. And if we want to say, why would that happen? So there is a possibility that you have active endometriosis that continues to be active after the menopause, or you may have endometriosis lesions that become reactivated after the menopause through hormonal exposure, which may come from HRT, for example, from internal estrogen production within the body, or sometimes unexplained but ongoing activation to whatever process of estrogen production happens within the endometriosis lesion itself. And that process of ongoing symptoms need to be kept in mind, because if a woman has endometriosis and has ongoing pain symptoms after the menopause, it's important to keep that in mind to say, do we need to assess, is there a need for an intervention to further assess and treat this? So HRT can reactivate endometriosis. So if a woman has a history of endometriosis, it's important to make them aware that there is a possibility that endometriosis tissue can continue to grow, and HRT intake may potentially aggravate it. Of course, some women with endometriosis may have aggravation of their symptoms, ongoing symptoms, without taking HRT, but taking HRT may increase that. Now, for the majority of women who take HRT, who have a uterus and they're taking estrogen and a progestogen, the progestogen component minimizes that risk, particularly if they're taking a continuous combined preparation. But one other area to refer to is if a woman with endometriosis has a hysterectomy and has the uterus removed, generally, out with endometriosis, that group would receive estrogen-only HRT. And in the context of endometriosis, taking estrogen only can increase the risk of recurrence of the endometriosis. So the general advice would be to say, if a woman with endometriosis had a hysterectomy, to give combined HRT with estrogen and progestogen given continuously, or to give tibolone, which has estrogenic properties as well as progestogenic properties as well as androgenic properties. So if a woman has endometriosis and enters into the menopause and experiences symptoms, we would say that it would be reasonable and safe to take HRT, but it is important that women are counseled about the potential progression or what effects endometriosis can have or what HRT can do to that. So it's important that women are counseled that endometriosis generally regresses after the menopause, but it may be reactivated and it may present with symptoms after the menopause. So if a woman experiences symptoms, that they need to seek advice to get information on that. It's also important to make women aware that there is a small risk of malignant transformation of endometriosis tissue. It's estimated to be in the region of 1%, so it is a small risk, but nonetheless it's relevant. So it's important that if a woman has a pelvic mass or a swelling with a history of endometriosis, to keep in mind that this may be a possibility. Often, of course, in clinical practice, if a woman has a mass, this will be investigated as any pelvic mass or abdominal mass will be investigated, but to be aware that there is a small risk of malignant transformation associated with endometriosis. And of course, whilst taking HRT may be a risk factor, it's also relevant to say that malignant transformation can happen in a woman with endometriosis after the menopause, even if they're not taking HRT.